We are a Medicare Shared Savings Program, MSSP, Accountable Care Organization, ACO, transitioning from the web interface to the APM Performance Pathway, that is the APP. So what do I need to think about to manage our participants to support APP reporting?
Great question, Georgina. The big difference between web interface and APP reporting is the number of data points you need. Web interface requires 248 patients for each measure. It's most easily achieved by distributing the pertinent subset of the required 248 patients to the practices that hold data on those patients and manually abstracting the charts to answer the important performance met question. But the all patients, all payer requirement of ECQMs and MIPS CQMs of the APP makes manual chart abstractions prohibitively expensive. Even the proposed Medicare CQMs is an enormous lift to perform with manual abstractions. No matter what method and what vendor you choose with which to meet the APP quality reporting requirements, there's a basic set of requirements you're going to need to fill and to help your participating practices fill. First, you need to know your participating practices. You know, the TIN of each practice, the location of each practice, and how many locations per TIN, the participating providers, key contacts, the inventory of health IT systems in use, practice management system, the electronic health record, the system vendor of each of those applications with key contacts, the hosting vendor of each of those systems with key contacts, and the data access contacts, not just organizational or business contacts. There can be multiple options to get data from each practice and each system. You'll need to identify the strengths and barriers existing for each practice and each of their vendors. You'll need to choose a workable method for each system for each practice and then implement it. Options include: you may utilize a database technician from the systems to extract the needed data from the health IT systems, from the databases. The person who writes the extraction can be from the practice, the product vendor, the hosting vendor, or even a third party. If it's a third party, that third party needs to get access to the data through the hosting vendor. A practice member can trigger canned reports that include the needed data. You have to identify if that canned report is written, if it's available, if it's accurate. You can use automated exchange of data per interoperability capabilities and requirements that certification is increasingly requiring. And you can use manual chart abstraction in some special cases. Now, there needs to be someone assigned to do that work. That person can be the ACO, or the work can be contracted from the quality vendor or registry you've engaged, the integration vendor you've engaged to electronically integrate your data, or another third-party vendor with the needed skills and experience. Common barriers to this basic organizational step includes: first, it takes a substantial amount of time, knowledge, and experience to do it efficiently and effectively. In my experience, ACOs never have excess staff on hand with the time enough nor the knowledge and experience to do it. It's not that the knowledge and experience are inaccessible to them. It's just very time-consuming to get there in the face of their already substantial responsibilities. Participating practices, more often than not, have reluctance to share data with their ACO. They may be willing participants and partners in the ACO, but competing with other ACO participants in many other aspects of their local care. So even though they're partners, they're a little reluctant to share their data with organizations that are also competing in other areas. Having a neutral third party mediating these details is often necessary to achieve the cooperation needed. Once it's set up and running, there's also routine maintenance required. Errors in the data are inevitable. They need to be recognized, understood, and addressed. Practices will upgrade their systems. This often changes the data flow, creating new errors that need to be recognized, understood, and addressed. Practices will change systems, that is, migrate from one one application to a different one, or they'll change hosting vendors, often requiring a new assessment of the best ways to get data and a new set of errors that need to be recognized, understood, and addressed. There are also going to be new practices and providers joining the ACO, each requiring a new assessment of their HIT infrastructure and decisions made for optimum data exchange. So no matter how you cut it, it's a lot of work to be done, and most ACOs are going to need help, not just a technical solution to provide their reporting.